it's my honor and pleasure. I've had an amazing last couple of months being able to work with Dr. Lombard. He is a very well-known, well-read, well-published medical physician. So he's got training in both neuroscience and psychiatry, which is especially super cool. So if you go back and look at some of the things that he's done, like a lot of the things we're talking about today is stuff that he started, more than 2 decades ago. He also spearheaded the development of the first gene replacement therapy for Batten's disease in collaboration with the National Children's Hospital, pioneering a groundbreaking treatment approach for this particular rare neurodegenerative disorder. He co-founded the Genome and played a pivotal role in translational genetics and neurology and psychology research, collaborated with interdisciplinary teams to establish robust algorithms and analytical frameworks, leveraging genomic data to inform medication selection, dosing optimization, and treatment management strategies, which is nothing short of amazing and super cool. Established and led one of the first acute stroke centers in New York at the Bronx Lebanon hospital under the American Heart Association criteria, implementing evidence-based protocols, multidisciplinary care pathways, and quality improvement initiatives to enhance stroke care delivery and outcomes. Also served as the chief neurology at Westchester Square Medical Center, fostering a culture of continuous quality improvement across clinical and administrative functions. He continues today in both a clinical practice scenario as well as collaborating on many research fronts, which again is super cool. I am Dr. Chris Proulx, so I'm actually the Vice President of Clinical Affairs and Strategy at Medray. I've been in this continuing education space for about 25 years between sports science and clinical and chiropractic. I was a full-time faculty member and researcher for about 15 years of that full-time, and then have continued part-time ever since. I remain in clinical practice as well, and still try and get some research done and write some things. As you all know, it's a little bit challenging to get everything done in there, but super cool. Really glad to be here. I appreciate everyone coming and taking this opportunity to listen to us. So it's actually our second webinar. So I'm new full-time with Medray, and so I'm kind of heading up part of this education aspect of things, and we're going to be doing more of this. So this could be your second one if you're also here. So I'm gonna kind of go through these a little bit first, just make sure we got everything. Hey, Mike. I have some fans here. Go figure. And so I'm going to get right into it and get into our presentation, which is based on peripheral neuropathy. So when we were starting this, and Dr. J and I were, kind of discussing sort of the format or what to get into, he has been associated with the chiropractic profession for the majority of his career, and working with many people in the profession. So it's kind of interesting that when we started chatting about this, and chiropractic, physical therapy, occupational therapy as well, but in general, the conservative medicine approach to dealing with some of these conditions. And so I thought that was pretty interesting as he was describing. He's like, honestly, um, these people in conservative physical medicine, like chiropractic, physical therapy, occupational therapy, are really well suited to be managing these conditions, especially knowing what we know today in terms of the growth in the population, but really the approach that also helps to mitigate some of the associations that we see as a result of these issues. And so, as we get into this neuropathy, and I know, and I recognize some of the names on the attendee list, and I know some of you have been doing this for a while as well. Um, but why this matters is there's a lot of opportunity out there to manage these conditions, which otherwise can really kind of change the course of someone's potential care. Part of my other side is I've worked in other areas of healthcare and dealing with lots of different organizations and other professionals, and in particular with prosthetics, and knowing that, you know, the um, number one cause of amputation in the United States is actually due to a wound that, you know, basically got infected and became problematic, and that's associated with one of the conditions that we're really going to talk about or really focus on is especially. So it often gets misdiagnosed. Sometimes it's just not thought of because a lot of people associate the reason for having a clinical application or getting treated is really because of pain, whereas a lot of these patients don't really experience pain, at least on the onset, associated with the neuropathy. And again, we're gonna get into this, but um, and studies have shown that we're actually, as if you're in chiropractic or physical therapy, you're about 10 to 15% of your patient population actually has neuropathy, whether, you know, that's been part of the discussion or not, right? So there are multiple predisposing factors associated with it. In general, what tends to bring them in is numbness or tingling or burning in the feet, sometimes also in the hands. I'm kind of a big gait guy, so I use that to detect. One of the studies that a previous organization I worked with, we were able to determine abnormalities in gait patterns even before diagnosed with diabetic neuropathy. And we're finally in a position today where we're seeing some opportunities to be a little bit more proactive in that instead of, you know, kind of waiting until there are wounds and whatnot. And that's another potential problem is that they do get these wounds or nail infections, predisposing factor, even if, you know, they may not think so, but absence of appropriate sensation while they're walking. So that includes like abnormalities with what they think they're walking on, as well as, again, that movement pattern. Gosh, depending on where you were trained, I mean, I think we all had these pathophysiology professors that were like, go down to the local, you know, XYZ, and you'll see some examples of like some of the things that we were talking about. And so, you know, one of them I remember from Dr. Van Duzen up at NYCC, you know, was talking about a particular patient that was basically walking on the medial malleolus. And so, again, that may induce pain at some point, but if there's loss of, you know, sensory interpretation, then that could be the biggest part of it. Obviously, dealing with the abnormalities in their walking pattern. Um, Frequently associated with the autonomic nervous system. And again, this is going to be partly due to the comorbidities, either other conditions as well as what's also going on pathophysiologically as a result of their condition or whatever it is. So it could be a history of diabetes, could be uh, chemotherapy, it could be like a vitamin B12 deficiency as well. Basically, what's happening is there's nerve damage. So there's axonal degeneration, we get demyelination, so it actually starts to shrivel up and really die. Remember, that's part of that saltatory conduction where we transmit the electrical conductivity through that axon. Why do I bring this up? Because when we get into what seems to help these things, we're actually really addressing some of these causative factors. Um, so basically damage, and a lot of it also has to do with this ionic shift of the delivery of oxygen into the cell, but also to be utilized. And so that's, you know, where you've probably seen about oxygenation, hyperbaric chambers, and things like that, which, you know, can certainly lend itself to part of the approach as the treatments that we're actually dealing with. So in one of our discussions, you know, we were talking about, you know, neuropathies where it's super important to make sure you've got the right one. In other words, you diagnose it and you treat it, you know, appropriately. One, because you don't want to miss it and then treat it as though we think it's something else and just chalk it up to maybe a diabetic neuropathy when it actually could be something else, and there could be some need for some co-treatment. But, you know, differentials looking at, you know, symmetry versus asymmetric. So our big one in this talk actually is going to be diabetic peripheral neuropathy, which is going to be typically very symmetrical. So it's going to happen on both sides. When it's asymmetrical, your differentials start to creep out a little bit, and there's some potentially other problems that are going on, but also even differentiating. And this is what's, when you look at the patient population that we might see both in outpatient physical therapy and chiropractic and certainly inpatient, physical therapy and long-term care facilities, is the comorbidity. So in the female population, the typical amount of comorbidities after the age of 50 is two to three, and then two for the male counterparts as well. In other words, they've got something else going on, so we don't want to just automatically chalk it up to blah blah blah, whatever it might be, and make sure that, by the way, you can have more than one thing going on. You might have a radicular pattern as a result of, what's going on in the spinal region, and may precipitate some abnormalities, which may look a little bit asymmetrical, when in fact that is part of the precipitating factors associated with why it's asymmetrical for otherwise a condition that could be symmetrical, like in the diabetic neuropathy. Um, so in our differential diagnosis, we want to make sure that we can separate some of those things. And in fact, I don't know if the clinician is on here. I haven't had a chance to respond yet, but they were asking some questions about, treating a patient with a young patient, in fact, with leukemia, that's experiencing, that's experiencing neuropathy that is not diabetic induced. And then another one actually came to me yesterday as well, which is looking at, a patient with another leukemia patient being treated or have been treated with chemotherapy, which chemotherapy is one of our differentials because it has that impact, especially on the sensory nerve fibers, with concomitant Charcot-Marie tooth disease, right? And so, which, by the way, it can, elevate the signs and symptoms of that particular condition just by getting chemotherapy. So again, the differentials are pretty important, and that's good because one, it's obviously going to lead us to the appropriate type of treatment, but also, creating those expectations. I remember, gosh, one of my first patients in chiropractic uh, practice when I opened my first clinic was, one of those patients, and it was challenging as a young stallion to, come up with those appropriate expectations and predictions, and making sure that, because we all want patients, right? And we don't want to scare them away, but the lifestyle was just not conducive to really what was going to be happening. So spotting neuropathy in practice, it actually doesn't have to be overly difficult. In fact, a lot of these patients will take on a similar gait pattern that we see with older adults in general, but that's challenging because that particular gait pattern, your other differentials are looking at other neurodegenerative disorders like Parkinson's or Alzheimer's, or loss of balance, and the whole cognitive piece associated with that as well. But it doesn't matter why. That's the cool thing about looking at gait, and why we call it the sixth vital sign, is it's a lot of information that we can really kind of use. And again, you can get really fancy or not, but loss of vibration and proprioception. Again, a lot of us are doing this in our evaluation procedures as a result of really any new patient coming in, but maybe adding a couple more to these, like a tuning fork test or a monofilament test, and making sure that, we're actually conducting our due diligence. Those are simple and easy. We may be able to, I won't say completely stop there, but if they also have the other associated cofactors, like they are, diabetic, they are on, the medications associated with that, they are on some of the other lifestyle factor situations that are doing that. So we can go more advanced. We can use diagnostic tools like nerve conduction studies, EMG, and MRI. And that's actually what's going to help us. So if we're not exactly sure, looking at a differential, whether or not it is the diabetic neuropathy problem, then those are the things that are really going to help us out. Your standard medical treatments, and this kind of goes back to why Dr. Lombard was like, yeah, he's like, man, this fits in in your guys' wheelhouse so well because of the things that you do. Because right now, standard medical treatments really just were, providing some medications and really a lot so dealing with the symptomatology in particular. And so, I think we've all had patients on gabapentin, useful in some aspect of some of these things. Um, Pain injections, topicals, they may have been sent to rehab. I have to comment. So the picture over there on the right is because when I first was showing the slide to Dr. Lombard, he's like, "Yeah, you could talk about this if you really want to put everyone to sleep." But it's just, kind of highlighting and make sure that we're all on the same page. Um, so the future and kind of where we're at is like these neuroprotective agents, light therapy, electrostimulation. But again, as I really, describe to patients is we're only going to get so far, right? Because if you don't remove the stimulus, and it doesn't matter what the heck it is in our office, that, if they're doing something really kooky that's causing their low back pain, bad posture, however they're utilizing their body, then that's actually going to be, very problematic, and not removing the stimulus really kind of limits our ability to do so. And that's where, diet and lifestyle come into play. The cool thing is that as practitioners in this space, we tend to have a pretty good captive audience, and we've done some really good things. I've had, many discussions and gosh, I don't even think I finished telling myself, but I am a chiropractor, and then I have degrees in exercise and sports science, and I've been fortunate in my career to travel a lot and publish and present and work with clinicians around the world. And so we all have that experience, and we all have those patients that, we do something amazing for them, and it gets to a point where we say jump and they say how high because they're so appreciative of that. So a couple of things that we're focusing on when it comes to sort of the in-office treatments, shockwave therapy being one of them. We kind of have three sort of orientations when we look at shockwave. So we've got radial pressure shockwave therapy. So extracorporeal shockwave therapy. Extracorporeal just means outside the body, right? So shockwave therapy, again, taking some different forms. And then there's focused, and then there's also sort of what a lot of people refer to as the defocused. That's using an acoustic wave pattern that's delivered into the patient. Regardless, there's a lot of overlap between these technologies, but they're all considered acoustic, shockwave therapy. But they all come from that lineage of lithotripsy. So lithotripsy is using a very, very high pressure, and even the pressures that we're using. We're not destructive in our world, right? We don't technically break scar tissue down. We disrupt the tissue matrix that allows for the body to instigate sort of these processes to resorb some of the stuff that doesn't belong there, as well as instigate new potential healing, right? So one is just mechanically speaking, it reduces the rigidity of the connective tissue. So that graphic over there on the left is actually radio pressure wave, right? So bam, we do it once and then we do it another one. All of these devices will have multiple impulses to it at frequencies typically between 2 and 20 hertz, which means 2 to 20 times a second that we're delivering that impulse into them. So this is radio pressure wave, in fact, um, which has the greatest amount of energy more at the superficial level. But as you can see, the pressure differentials, the MPa, the Pascal measure zero point 0.5 in the red, negative zero point 0.5. So don't think of, just a positive pressure, but there's actually a negative pressure. And sort of the introduction or the analogy I like to use, and it's not quite a shock wave, but like when you do a cannonball into a pool, and you go in and it creates this pocket around, and then it fills up very quickly and it shoots this big splash up into the air. So positive and negative pressure actually have these implications, and really, at least within the human tissue, it needs to be rapid to be able to accomplish that. So that's why this is different than percussion. But even looking at, the chemical mediation that it implies, actually stimulating from a neurological perspective the release of certain chemical mediators. We can reduce some as well and be inhibitory as a result of that, like substance P. Endothelial nitric oxide, as you can imagine, is going to have something to do with releasing oxygen. And I mentioned that a little bit earlier, especially when we're dealing with diabetic neuropathy or neuropathies in general, is that limitation of the oxygenation uptake for metabolic purposes in the cell, right? That's why stuff dies, is because it doesn't have ATP to form its functions, right? And therefore, when we don't have oxygenation that is utilized, that's the problem. And that's why we're limited. If we just want to like throw oxygen into the area, it doesn't always stick to the wall, as they say. We're leading a horse to water, but it's not necessarily drinking. Versus some of these processes that we conduct actually stimulate that ionic shift. In other words, it tells the cell to pull up that oxygen, um, and actually metabolize it. And in particular, when it comes to metabolic activity, and what we all like when we talk about laser as well, is that cytochrome C oxidase process, right? The spinning of those cytochromes inside the mitochondria to, I know, bad memories, phosphorylate what's going on inside of the cell. And then we've got apoptosis.
I want to add on to some of the points that you're making here because as a
Absolutely.
neurologist, most of the patients I see are post-stroke with very, very high degree of rigidity, and, flexion of various muscles. And my experience with shockwave therapy is it significantly relieves spasticity. And I think the primary mechanism of how it relieves spasticity is by impairing the junction between actin and myosin. Because after a stroke or after traumatic brain injury or after a cervical cord injury, spasticity is mainly due to a hyperactive connection between actin and myosin. So I believe, and it's not only my opinion, that the benefit of shockwave therapy is to literally improve spasticity by breaking up the actin-myosin bond that occurs in muscles related to spasticity.
It's an excellent point, because even if you're not treating stroke, that example is very powerful in terms of if it's doing that with stroke, also one of the reasons we see that same potential disruption in our patients generally, that may have a hypertonicity associated with, when there's nociception, there's an increase in the sympathetic nervous system, which is firing up, and obviously also creating some protective mechanisms. So again, absolutely in the stroke patients, and certainly, anyone sort of kind of below that level. And that's a very, very powerful thing. And think about that if you're doing decompression therapy or other mobilizations, and or even in, retraining some of those things that we do with stroke patients. And then another one. So earlier, before we had really good technology or good studies, we used to think, we saw a calcific tendonitis and we bam, 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 we shockwaved it, and then we re-imaged and it was gone. So again, we used to think that it was blasted away, and that's not the case. And actually, the relative importance of this apoptosis, in that it causes that reduction in, as I call it, a slap in the face, that foreign matter where it doesn't really belong someplace, and that we really need to remove that. So specifically in the mechanisms associated with diabetic peripheral neuropathy that we might care about, the neovascularization stimulus is huge. And we see this in like similar areas, like in erectile dysfunction, for example, where, we have sort of this degradation in both the neuro and the vascular flow to the areas. The cool thing also, not only is it potentially sparing, but also assists in that regeneration process, and as we already described, the potential reduction in nociception. Um, The connective tissue compliance is also, again, for those of us that are in that physical medicine space, is huge if we're trying to reestablish some normal tissue patterns, regardless of where it is in the body. But again, thinking of these patients that also, as a result of their conditions, have some abnormalities and have created some of these more antalgic, positions that are facilitating some of these other problems. We've even seen the neuromechanical reset, which is one of the things that was especially interesting to me, as we would see a reduction in motor neuron excitability as a result of doing that. Which, if you were dealing with an athlete, obviously that would be detrimental to overall performance, but it links back to also kind of what's going on in nociception and breaking, part of that bond, especially from a neurogenic effect. So in summary, clinical relevance, reducing pain, dysthesias, enhancing the local circulation, improve function and sensation. And if we think about that too, from the perspective, like when you're giving them exercises and whatnot to do, um, that's important because they're also exercise in general is very repetitive, and we kind of want to do that in the right positions and making sure. Prevention of ulceration is very important as well. As I described earlier, it's that ulceration that went bad, that is the number one cause of amputation here in the United States, which, as I mentioned earlier, getting that prosthetic thing. And absolutely feel free to jump in here, Dr. Lombard, any tidbits or things that you're seeing as well.
Sure.
High intensity.
Yep. I think it's an important point that angiogenesis is really what I would call the major goal of improving nerve regeneration, because without blood supply, nerves cannot regenerate.
Right.
And we know there's a direct correlation between neuropathies as well as myelopathies, including neuropathies. All are fundamentally related to some dysfunction of blood flow. So the whole intention of the technologies that are being displayed here is really about increasing nitric oxide. And nitric oxide increases blood flow, and increasing blood flow increases angiogenesis. And as far as long-term, the goal of regeneration starts with angiogenesis. So it's probably
Yeah.
the most common modality that infrared um, and shockwave therapy have in common. Even though they're different modalities, they've both been proven to promote angiogenesis and therefore nerve regeneration.
Absolutely. And that we just did a talk last month, sort of looking at the combined effects, either um, within a treatment or, through a process where we may have introduced one versus the other. And that's, what brings us into photobiomodulation. Now there's some overlap in some of this. To me, like one of the overt benefits that we see with laser over, some of these other forms of light is also that it's been shown to influence insulin sensitivity. So if that's kind of in the bucket of problems that your patients are having, but like Dr. Lombard said, there's a lot of overlap, with these two, and I think there's some shining factors. Obviously, with light, the stimulation you're going to get from high intensity laser is really going to be through thermal implications versus the pressure implications that you're getting. So even though there might be some implication with regards to overlap, there's also some different pathways that we're dealing with, to sort of accomplish that. Same thing in this metabolic. One of the things that excited me with laser from the beginning, and at that time, like I was really dealing with athletes and athletic populations. And so our goal was really to take care of stuff as soon as possible because we don't want scar tissue formation. Like a hamstring injury would result in potentially a career-ending injury for particular athlete. So reactive oxygen species is super awesome. So that's been measured in looking at a chemical process that's mediated by an enzyme superoxide dismutase that What we know is that we're delivering the oxygen, but there's not excess, right? Because, and I know some people hate it when I remind them of this story, but oxygen that we breathe in is diatomic, right? It's not a stable, element in and of itself. So it lives in the air as O2, but when we bring it in the body, we separate it because it's one O that combines with two hydrogen ions in that, right? That cytochrome oxidase spinning cycle. So H2O is our byproduct, right? But we don't want a lot of extra O there because that would be, kind of detrimental. We find that especially laser because it's it's very comfortable, it's easy, it's high satisfaction rate. So if you do have some of these people that are overly sensitive, that's where laser therapy might be a little bit different. So we look at, the relevance here, where it really kind of fits in, and it's again, there's some overlap here that we see with the other form of energy in shockwave. But again, if we think about this from the perspective of when we would like to implement it, versus, just thinking that either they compete against each other or, do we need to do both of them? And sometimes we do. So, um, really good for sensation, pain and paresthesia, because it does have a thermal sensory impact to it. So if we think about the mechanism associated with peripheral neuropathy and where that, really also kind of fits in. And it's actually, even from the literature, been shown to slow the progression of neuropathy, even if we're just trying to mitigate, some of those factors. And this is one of your favorite picture GIF files, right? um, so in office, if we think about, in the conservative space, and what do we exactly have to offer? And so, chiropractic adjustments or manipulation therapy of the spine, if you're a PT or a DO, we all have our own name for some of these things. I know we've got a combination of folks on here, but the reason for that is, what we're doing from a mobility standpoint, what we're also doing. We know that there are some chemical mediation effects that actually make their way up to the cortex and even go back down. So a lot of people are already doing that. And then we've got our photobiomodulation, shockwave. The balance and sensory rehab aspect of it, I think, is hugely important. And not everyone has like that space in the office per se, but to be part of even something that might be done at home, to then start to develop that empowerment and making sure that, they're adding their stake in the game here, and that, not everything is going to be a passive aspect with regards to the treatment, and certainly what we're getting from, both antero and retrograde stimulation as a result of doing some of the more passive things in addition to the more active things. Patient education handouts, like, this is a pet peeve of mine in particular, because yeah, can't just hand them something. One, you need to make sure it really matches with your patient population, right? And so, whether it's language, age groups, and things like that. But when I hear like people giving out exercise therapy, it's really important that there's some means, something solid that they can look at or touch or read. And even me, I use a software that I send patients my information. But if they are not, adept at using technology, then, patient handouts can be really, really important. I think we also agree that the at-home care aspect is hugely important. And that's where these are things that they can do at home, and these are things that they can also do, again, to develop that empowerment. And we find this in various aspects of health, wellness, and clinical care, that as they become more involved in their own promotion of healing, getting better, at least progressing, the opportunity that we can do. So we like to use an at-home product that also has multiple wavelengths to it. It's not laser, it's utilizing LED, which is fine because we have some opportunities using some similar wavelengths, obviously at lower power, using various wraps and supportive products in the lower extremity as well as in the upper extremity. One for stimulation. Because that can actually help with some of their proprioception, right? If they're wearing a compression sock or something like that, but also the 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 vascular flow as well. Um, we'll talk here in a minute and love to get Dr. Lombard's a special take on like the nutrition aspect, but things that can actually support nerve stimulation and their overall compliance, which again are part of the handouts and I have my favorite topical and you hear me talk about that, but in general like a menthol product. And so and this is where I get into it a little bit with people. I'm like, yep, you could tell them to go buy it at home. I'm always leery about just sending people to Walgreens or CVS or whatever when, and it's okay to actually carry some of these products in your office to make sure that they do that. But also there's some different levels. So like this one has the highest level, which is a 10% menthol, also has MSN in it. And I'll talk about this again in a minute. I actually use it during Shockwave as well. Um, and when we were talking about this and Dr. Lombard's like just compliance, in that a biggest measure really is, I mean, obviously we can go back to and look at our diagnostics, but are they really doing what, is necessary? And I think Dr. Lombard, we can probably agree that if compliance is there, it will probably correlate or match with our diagnostics as well.
And what I usually tell patients when they undergo shockwave or laser therapy is to set expectations that we're not looking for a cure. We're looking for incremental reduction in pain severity. So I have patients keep a pain log that after administration of whatever modalities that we're using, whether it's pharmacological or biomechanical, uh, it's great that they chart their progress symptomatically because they now feel that they're being listened to as opposed to saying, okay, well, if you just need, 24 more treatments. So I think that's always a good caveat when you treat patients is to have them self monitor their pain levels from visit to visit.
I can imagine that also ties into like just the overall psychology of compliance, right? Instead
Yep.
of someone else telling them they're getting better, that
Right.
they don't always necessarily see it themselves unless it's pointed out, or it's something that they get invested in. And then we've been having these discussions, and I know some of you are also using thermography already. But there's some interesting opportunity in not only for this, but in some of the other things that we're dealing with. And I know in particular, Dr. Lee also uses thermography because it's going to be related, to a heat thermal image that is associated obviously with blood flow and especially what we see in the extremities. So we wanted to just throw a couple of cases in here. So the I don't promote any specific program. If you know me, I've been doing decompression stuff for many years, and I've never. So these are just the result of any patient I get, and I think what's interesting um, is again a lot of comorbidities that we see in our patients and making sure that we realize that. And I always tell the story, and it was just recent when I was talking with a wellness clinic that does, testosterone replacement therapy for men, estrogen for women. And I was asking specifically about men. I'm like, what percentage of your patients on TRT are also experiencing another arguable neuropathy, which is erectile dysfunction. And they said, we don't really get any of that. And I said, are you asking? And they're not. So kind of leading us down and thinking that if a patient fits the bill, then make sure you're looking into this. So this particular, really kind of on the classic side of things, but again, we want to make sure that we're dealing with it and evaluating it appropriately. Monofilaments and vibration, again, simple, and especially on the vibration aspect of things. Obviously, they're not the best tests, but they may get you across the finish line to some degree to at least make some determination whether or not you need to refer them. Um, like I said, I always use gait, so we do have some gait biomarkers and analytics associated with a pattern that we might see. Now, it's pretty sensitive, but it's not specific, right? So it could be that obviously this patient is a 68-year-old male, and maybe he's just not physically active, which, by the way, he's not. So I tend to see a lot of this in that patient population anyway. And then looking at the skin, and again, a pain scale that we discuss, and then there's some really good forms out there as well that can be utilized again for them for tracking and things like that. So we do want to rule out things like some small fiber neuropathies, the lumbar radiculopathy. Again, there's no law that says they can't have that too, and that could be a reason that actually brought them in to begin with. Looking at B12 deficiencies. So this is where you're actually going to have to get some measures and then confirm, looking at the symmetry. But again, be careful because there could be an exacerbation more so on one side due to one of those conditions. So I use high power laser, and I've been using laser in clinical practice for about 25 years now, radio pressure wave for almost 18 years. So they've become a pretty big staple. And again, you can connect those dots and tie them to as we've already discussed. So laser, like I said, works really well. It's very comfortable, especially works during those, I think those early stages. If they are apprehensive, if they're a particular new patient, Shockwave, it doesn't have to be extremely uncomfortable, but it might be a little bit uncomfortable for some of these patients that might be new to this. Now, when we're looking at laser, so I'll do that especially 2 to 3 times a week. So we want to make sure that we're seeing these patients frequently enough. And that's a discussion that, I get into a lot with clinicians where they say, well, patients can only come in once a week. Well, then you better have a really good at-home program because, doing some of these things once a week, I would have limited expectation, especially in some of these passive modalities. I will say that radio pressure wave, and the reason I do this 2 times a week in some of these populations is especially because I'm using some lower energy densities. So 60 to 90 millijoules, think about that more like, 1 to 2.5 bar if you're using one of those other pneumatic devices. I like to use higher frequencies here. I don't need to go really deep, right? Because we lose depth of penetration when we move up and have a lot of these really high frequencies. But because it really matches up, and that's a really good frequency to get overt stimulation, and especially if they're in pain or uncomfortable.
Hey,
The
Chris,
home,
Dr. Patel had a very good question in the message box
yes.
regarding going over specific protocols. I think we do that on these case studies, but if you just want to reiterate that question or answer to that question, that'd be great.
Yeah, so if we think about the algorithm of obviously the patient presents themselves, and again, it's not my classic approach. Like I don't target specific people. So when they come in, I have a listing of what I treat. So they come in, we find out what their problem is, and if it is, something where they've got some numbness or paresthesias or abnormalities in their lower extremities, that's usually and they enough people have Googled it to where some of them actually think they might actually have a neuropathy even before you get to your diagnosis. But in any event, obviously the diagnosis, and we kind of hammered that away. But if we think about um, the opportunity that we have and what we need to accomplish. Keep in mind that these patients are they're on the low end, biologically, physiologically, in terms of, as I call it, on the downside of tissue regeneration. So we really want to make sure that we take that opportunity and we need to elevate that, as I call it, rather dramatically. So I won't even agree to see patients less than 2 times a week during this earlier phase of treatment. So typically, classically, we would want to see them 3 times a week. Um, for at least the first 3 weeks. And that's where we're introducing our laser therapy. So if I'm doing that every single session, and I do laser therapy every single session for that first front end, because it's really important to develop that. Here's what's kooky, and people look at me funny when I talk about and present, laser therapy on infection, for example, or very acute conditions, is we do that 3 times a day. People are like, well, how do you do that? They don't come into the clinic 3 times a day. Well, just because, that's how the clinical world works, it doesn't necessarily mean that that's how normal physiology works. And again, that's why it's so important that we get that opportunity and we match up the physiology, the pathophysiology with the treatment physiology. So 3 visits a week typically, and we're irradiating every single time. We're also doing your chiropractic manipulation therapy. This is also within the first week or so, we want to introduce them to the neuroboot. Now, I don't do everything at once, and here's the reason why, is because it's very difficult to track and make some, assumptions. I'm big on that, patient psychology piece and making sure that we're on the right track, but also setting the tone for what we're doing. And then approximately at the end of that first 3 weeks is when we're going to introduce the radial pressure wave. And that I will do 2 times a week. And the reason for that, and we see the literature is especially strong in the erectile dysfunction, where you can get away, as I call it, get away with doing it 2 times a week because you're using lower energy densities. And it was something, we started looking at this for at least 5 years ago. I was using RPW on TMJ and everyone thought I was crazy. And it's like, well, if you take the appropriate precautions, use the appropriate energy, and that, by the way, you don't have to kick the crap out of someone to make it beneficial. And we've seen subsequent support of that nature. So I was at the ASMST a little over a year ago, and Professor Dr. Karsten Knobloch even commented on this on one of his presentations, and I talked to him about it after the fact. But he had posted on this as well, and Dr. Kovac even published this in a study where pressure differentials have been shown as deep as 7.2 centimeters. In that, the clinical relevancy, we don't know the bottom end, but we're seeing it come down and sneak down. So what do I mean by that? That's what allows me to use lower energy densities 2 times a week to facilitate some of these more initial changes. So we're usually on some of these classic areas, especially where they're experiencing these paresthesias. I always start on the low end, and that includes both the energy density as well as the number of impulses. So yes, the literature shows that your classic range is 2 to 4,000 impulses, with obviously a mean of 3,000 impulses, but 1,000 impulses can also be impactful. So we start initiating that 2 times a week during that last week of laser session, and so this is where there actually is stacking. Why do I do that? Well, there's there's not a ton of papers on that, but I presented on this last month, and anyone that wasn't there but is interested in the recording, send us a message. But so we've got a couple of papers looking at the overlap of those two modalities being conducted simultaneously within the same treatment session. For me in particular, I'm a huge fan of not creating scar tissue, but really optimizing what's going on metabolically, especially with that reactive oxygen species, and making sure that we're able to deliver the energy that really is not only going to stimulate that process, but then we need to continue it. Also, within that second week, So you see that we added something new. We didn't add everything all at once, but within that second week, so in between when we started with laser and when we started with shockwave, in that second week is adding the home therapy aspect of things, and that's where the NeuroBoot comes in. And that's a daily process. And that does a couple things for us. One is it's introducing continuous red light. So when I mentioned this earlier, I'm like, when we look at some of the studies in treating infection, for example, where we would do that multiple days, because by the way, laser is antimicrobial, the benefits, come from doing that. And if you look at studies, well, oh, that didn't show a benefit. Well, if they only did it once a week, that's why. It would be like taking your blood pressure medication once a week. So there is a dose response to this type of therapy, very similar to pharmacokinetics. And then the in-office functional exercise, we start also within that second week, again, not to overwhelm people with so many things all at once. And, Rome wasn't built in a day, but starting it in office, make sure people that they know what they're doing. And then they do that at home. I don't have the space, I don't have the time, for people to be in the office for an hour and a half. And in fact, that's the layering of sort of that empowerment. And then lastly, on the footwear aspect, um, so I actually just wrote a program and an algorithm and working with a company and developing remote therapeutic monitoring. And so because we're that sensitive with regards to movement pattern, that, especially shear force as well as compressive force. So we want to make sure that they don't have abnormalities with regards to forces. And you'll see that a lot, especially that, people that are numb. So it doesn't have to be hugely expensive. The other benefit of like some of these more over-the-counter ones, initially to start with, is they're very cushiony, and that's going to reduce some of the impact loading that we see as a result of, some of these abnormal patterns in this patient population. So because we're doing the at home, and I'll tell them just keep doing it every day, and that if they're doing the at home therapy every day, including the NeuroBoot, this is where we can start to taper off. So after that third week, and it'll kind of depend a little bit about, how progressive they are. But by the way, this is not something that happens like that. Same thing if you're treating wounds or non-union fractures, and that I think is a challenge for some people's practices. But this outcome, and you may decide I'm a 6 to 8 week kind of guy, in that how much do we need? So when we start to do a taper by that sixth week to determine whether or not the in-office is still going to be beneficial, or is it really up to them at this point to continue their home care? Again, this could be your type of practice, and it goes back to, Dr. Lombard's discussion on the compliance aspect of things. I measure a lot of functional stuff. Like I said, I measure gait, and so when we see these improvements, then it probably means they're definitely on the right track. But hey, everyone has some setbacks, and easily enough they can come in. We don't have any data that says that doing laser again at 12 weeks or a year later is detrimental. Same thing with shockwave. In fact, we found that we can really pick up where we took off. And here's the reason why. They fall off the wagon and they're not doing their exercises. They're not doing really what is necessary to mitigate, that pathogenesis, or the reasoning that, they're having some of these problems, which could be nutritional, lifestyle, and so on. So this one's a little bit younger, newly diagnosed with pre-diabetes. So again, some of the statistics on that, why are we talking about this, is it's the patient population. So we've got over 50% of the US adult population that is at least pre-diabetic. We have depending on the demographic, between 1 and 2/3 have a high BMI that puts them in the overweight and obesity category. And so there's a lot of people out there that potentially do this. And I'm always a fan of like being more proactive. But in any event, this person actually does have a complaint that's associated with a neuropathy problem, and they are in fact being managed for it. They are in fact also on metformin. So very similar, clinical evaluation that we would do for the monofilament vibration reflexes. And again, I have a gate process that is just part of my part of my intake for every patient, not just these particular patients. So again, we're looking at trying to rule out all those other problems to make sure that we are in fact diagnosing them with what we're supposed to be treating with them. So this was 2 times a week, so a little bit younger patient. Um, my biggest concern for this patient is even at 57, just the lack of physical activity, the lack of motivation, dietary intake, all of those factors, and succumbing to 2 times a week it was a challenge because I wanted 3 times a week. In fact, I wanted 4 times a week, but it was a challenge there, but we got to it. So a bit of a similar process, but as we started to taper, we went back to using Shockwave 1 times a week, and that's where the literature really is anyway. And when that happens, and that actually fits into some other clinical models, when you're doing that taper, but when that happens, you can be more aggressive. And actually, I show patients that where we started off here at say 60 millijoules, now we're up to 90. And the reason that that's actually beneficial in their mind and in mine is their threshold of discomfort changes, right? And so when they can withstand more energy, that's actually a really positive factor, not just within the neuropathy piece, but within some of these folks anyway. We did initially start off every day. They weren't compliant. And here's the problem, and I had very few patients that would overcome this, but in general, if you tell people to do 10 things at home and they can't do all 10, it's not like they choose the top 3 or 4. They do zero because it's this failure implication. So that's why we're very careful in making sure that we match that up. Although I had a patient come in, he was a young guy, he was an athlete, and it was at the university clinic, and he came in and I said, yeah, why don't you go ahead and do your exercises, and then, we'll get into some of the other stuff later. Like, I didn't see the guy for an hour. And I went to look for him and I found him, and he's there doing these exercises. I'm like, "Where'd you go?" He's like, "I didn't go anywhere." And I look at his, like, what they would do in rehab is they just kept adding to. So he was doing his remedial exercises and just did a whole hour of like all these things. And but again, that's not usual. And so unfortunately, we do have to kind of play around a little bit. And I'm not as much of a hard ass as maybe I put myself out there to be. But so we had to comply with this. We had to figure out a way that they would comply to this. And it did work out well. So again, the conservative management. But I will say that they were really good with their at-home compliance, doing the exercises and the things that they were supposed to do. And that's why, again, I was a little bit more lenient at 6 weeks because we saw a lot of that reduction. Now I give people the option. I don't push too hard. I kind of leave it up to people, monthly, quarterly, whatever that might look like to you, depending on what else they're doing. I have a lot of people that transition into quote unquote members and stick around like for forever at some point in time, because they don't want this stuff to happen anymore. So, as we always like to say, there's a Monday morning take home, some stuff that you can do at home, and again, asking better take intake questions, balance exercises, nutritional support, turmeric, alpha lipoic acid, magnesium, agmatine. Did I miss anything? Is there anything else, Dr. Lombard? I think we've covered all the big ones
I,
that we had
I
discussed.
think you've done a phenomenal job. I want to reiterate the importance of differential diagnosis, as you mentioned.
Yeah.
In case number two, you always want to make sure that you're treating what you're treating, and know what you're not treating. In my experience, a lot of patients have comorbid lumbar stenosis with neuropathies. Um, And so it's both a differential diagnosis, but it's also a comorbid condition
Right.
that you're likely to see.
Absolutely. And there'll be some overlap in some of the benefits that you'll get from, the approach that you'd be doing both. So those of you in the chiropractic space, if you're going to FCA, that Medray will be at FCA, so you can, take a look at all the things that we were discussing. Excuse me, as well as the neuro boot. But again, reach out. Like, my job is answering questions, which is kind of fun and cool. And so, if you have any questions, then absolutely. And honestly, the other cool thing is I love getting, other people's cases, and we'll chew the fat on it a little bit, and so it just allows me to then, kind of continue and share that. Anyway, take care and stay cool.